Request Dr. Sudipta Mukherjee, Consultant Critical Care, TMC Kolkata. Sir, please.
Good morning, everybody. And to begin with, I'd like to thank Dr. Pratik, Dr. Karmakar, and the whole team for a new journey. That is the Howrah Critical Care Society, and we hope to work together in long run, and we'll learn from each other. And it is probably the perfect day. The sepsis day, or sepsis week is coming, and probably in critical care, the sepsis is probably the most important aspect or the most challenging aspect for any intensivist, because it has a high mortality, along with it causes significant cost even when the outcome is not optimal or not as per expectation. So in next 20 minutes or so, I will try to give an overview of the sepsis in the present era. I try to raise some concern or the challenges or the change in the shift in paradigm regarding the sepsis management, which needs some food for thought and probably need more data in the coming days. So I will try to touch upon the definition and diagnosis of sepsis, and the most important aspect of sepsis, that is the initial resuscitation, which comprises of fluid, pressure and steroids, antibiotics and biomarkers, so that we can differentiate or diagnose sepsis appropriately and optimize our therapy to have a better outcome. At the same time, can prevent overuse of antibiotics so that we can prevent or decrease the chances of development of resistance. In terms of ventilation, and what are the rescue therapies presently we are working on in sepsis management. Now the term sepsis is not new. It was first documented in the year around 2700 years ago in Homer's poem. But the understanding has changed from those days. So initially it was come from the Greek word sepo, which means I rot. And eventually in the present era it means decomposition or decay. Subsequently it was used in the work of Hippocrates and Galen in the later centuries. And in the 1800 year, when the germ therapy of disease comes, sepsis probably originated from the responsibility of the cause of sepsis was landed onto the harmful microorganism. In the year 1914, first time the Hugo Sockert-Muller tried to define sepsis, and he says that sepsis is present if a focus has developed from which pathogenic bacteria constantly and periodically invade the bloodstream in such a way that the cause is subjective and objective symptoms. First scientific definition of sepsis, the sepsis 1 definition, come in the year 1991, and the journey of surviving sepsis guidelines in terms of the initial management and resuscitation of sepsis start in the year 2004. Now, why we are so concerned about sepsis? Because the global burden of sepsis, irrespective of the boundaries and the country and the continent, is huge. It is one of the major causes of morbidity and mortality in critically ill patients, and the total load is very difficult to ascertain. The global epidemiological burden is probably more than 30 million, and 6 million deaths probably annually happening. The one data we have in the year 2017, when we found the global sepsis-related diagnosis is around 50 million, when 11 million people has died, which contributes nearly 20% of the whole death in the world related to sepsis. And the data from the surviving sepsis guideline in 2012 had shown the mortality in the European countries is around 41% of the sepsis, contrary to the United States it is 20.3%. So it is little odd that the mortality is nearly 50% less in the Western country, in the America compared to UK. But we need to do the severity assessment and accordingly optimize the mortality in terms of severity. Then it shows that they are basically comparable in terms of the outcome. So that means whenever we are talking about sepsis, though it's a very generalized term, the severity and outcome mainly depend on the severity of the sepsis and the associated organ failure compared to just whether the patient has sepsis or not. So, but in last few years, there is a definite improvement in the outcome of sepsis. It shows in the multicentric study in Australia and New Zealand. They've done it in more than 100,000 patients, and they found that mortality has decreased significantly over last 10-12 years, nearly from 35% in the year 2000 and probably 20% in the year 2012. Now, we are working in the critical care for last 10-12 years. We also know in the initial days, the people who may be on ventilator on requiring 2 inotropes are rarely survived. Nowadays, this is not a big challenge with 1 or 2 organ failure. Now, look at the journey of sepsis or understanding of the sepsis from the physician's perspective. So, initially in the 1919, when the first time surviving sepsis definition 1 comes, they usually define sepsis infection along with SIRS criteria, that is systemic inflammatory response syndrome criteria, which involves temperature, heart rate, respiratory rate, and the WBC count. And when they define severe sepsis, when the sepsis is associated with certain form of organ dysfunction like hypotension or tissue hypoperfusion. And septic shock means sepsis-induced hypotension despite adequate fluid resuscitation. That means whenever you have replaced the fluid, still you are requiring certain amount of vasopressor to maintain the blood pressure. But what are the problem with this? Problem that it does not define the outcome. It could not prognosticate the patient just on the basis of these terms, because they have not structured or objectified the severity of the organ failure or associated definition of the organ failure. Next, in sepsis 2 guidelines, they define that sepsis is infection, along with there are other parameters. They try to generalize, try to identify all the risk factors or the associated clinical findings related to sepsis. Some are general parameters like the search criteria, inflammatory parameters like leukocytosis, procalcitonin, CRP, hemodynamic parameters like whether patient having an hypotension, requiring fluid resuscitation, or beyond fluid resuscitation they are requiring blood pressure support with noradrenaline or other vasopressors. What are the organ support this patient is having? Maybe hypoxic respiratory failure or maybe acute renal failure. And what is the situation of tissue perfusion? So in terms of lactate and also capillary refill time. But again the problem is same, there is too many points to define the sepsis objectively. If you go back to the past, this was a quote from 1904 by Sir William Osler. He says that except for few occasions, the patient appears to die from the body's response to infection rather than from the infection, rather than from it. So for the first time in the surviving sepsis definition of 3, we accept that sepsis is basically a life-threatening organ dysfunction caused by dysregulated host response to infection. It is probably not the bug, but the body's response to the infection which determines the outcome and determines whether patient will live or die. And here they try to objectify sepsis as a life-threatening organ dysfunction. And it differentiates clearly between the infection and sepsis in terms of the clinical condition of the patient. And why it is important? Because of the prognosis. Because we know when the patient is in sepsis, average mortality of this patient is around 10%. Now once they develop septic shock, that means they are requiring blood pressure support even after fluid resuscitation, and the mortality increases from 10% to 40%. So there is a clear tendency or effort to objectify the sepsis and its outcome in terms of organ failure and hemodynamic instability. And they objectify the organ failure in terms of the SCOFA score, involve all the major organs like respiratory system, coagulation, liver, cardiovascular, central nervous system, and the renal. And it was very obvious that once the score increases from 0 to 4, there is a significant increase in the mortality and poor outcome. So most important aspect of sepsis is the initial resuscitation. So it was initially started by the surviving sepsis guideline when they give a time-bound bundle. They mentioned that few interventions need to be completed within 3 hours, and some intervention need to be completed within 6 hours. These interventions has remained same over the last 15 years, and there is very minimum modifications, like we need to measure lactate to see the severity of tissue hypoperfusion, obtain blood culture so that we can optimize our antibiotics accordingly, start broad spectrum antibiotics as per your hospital protocol or the anticipated infection that you can that is happening in the society or in your hospital, administer 30 ml per kg of crystalloid for hypotension when the lactate is more than 4 to optimize the tissue hypoperfusion. And within 6 hours, the target will be to apply vasopressors if the patient is hypotensive and not maintaining blood pressure even after initial fluid resuscitation. And in case of persistent arterial hypotension despite volume resuscitation, repeat measure lactate, measure CVP, and measure SCVO2 in this aspect. There are some changes that happened, but the most important understanding is that time in initial resuscitation of sepsis. So studies have shown that if the initial resuscitation is delayed, and even within the stipulated or the recommended time period, there is a progressive worsening in the patient's outcome. So this is a paper which has been studied on 50,000 patients, and they have found that there is a risk adjustment increase in mortality with decrease in the resuscitation period, even within the range of 3 to 6 hours. So what the recommendation in the 2018, they make from 6 hour bundle, they make the whole thing in the 1 hour bundle. I try to streamline it a little bit more so that the interventions can be practiced in majority of the scenario. So they have taken off SCVO2, and we understand the CVP does not probably indicate the volume status, so we have taken off the measurement of CVP. So rest of the things are there. And another thing they have emphasized is the initiation of vasopressor. Previously, it was fluid resuscitation followed by vasopressor. Now, recommendation is we need to start vasopressor if the patient is hypotensive during and after fluid resuscitation to maintain mean lateral pressure more than 65. So, we have identified the need to start vasopressor early during our resuscitation period. And this has been proved in multiple studies that shown that if you start your vasopressor early, patient having a better outcome. Now, whether to give crystalloid or colloid, probably this fight has over. So we know that presently the fluid of choice when we are doing the initial fluid resuscitation is crystalloid, and the surviving sepsis guideline has recommended crystalloid as a first line of fluid therapy, and they have suggested for albumin in patient who receive large volume of crystalloid after overusing crystalloid. Once you have given enough crystalloid in this patient, they recommend against starch for resuscitation, and they suggest against gelatin for resuscitation. Why there is the recommendation against gelatin is soft? Because there is not enough data. We have stopped using gelatin for a very long ago, and whenever we have used to use gelatin, there was no ethical committee. The volume of gelatin people has used is very, very high, 40 to 60 ml per kg, which is not at all acceptable in the present era. And it has been proved in multiple studies, starting from Success trial, Sepsinet trial, Chess trial, Christmas trial, Crystal trial. Most of the studies have shown that colloid, even though it is costly, does not help much in the initial resuscitation in terms of outcome, and probably some studies shows poor outcome. Even the Success shows high mortality when you are using colloid. What about albumin in septic shock? It was first identified in the Albios trial as a subgroup analysis. It's shown the patient who are in septic shock with albumin less than 3 gram per dl, 5% albumin resuscitation along with crystalloid shown to have a better outcome. And it has been again proved in the systemic review and meta-analysis. They found that if the initial fluid resuscitation, when the patient requires a very high volume of fluid crystalloid, if you combine albumin, probably they are having a reasonably better outcome. But this has not been proven in other randomized control trial that has been followed after Albios. But what about between normal saline and balanced salt solution? Probably this fight is still going on. We all are aware that surviving sepsis guideline recommend or suggest for balanced salt solution for fluid resuscitation, specifically when the volume is very high and more than 2 to 3 liter. Because it can cause hyperchloremic metabolic acidosis, and hyperchloremia can cause renal injury because of renal vasoconstriction. But again, if you look at the evidence, that's a low quality evidence with a very weak recommendation. Because we all are aware that every year there is a new paper comes, some says the balanced salt solution is better, some say normal saline is reasonably okay and it is cheap. So probably we are not in a situation to conclude anything. But from physiological aspect, whenever you are using large volume of fluid, a balanced salt solution is a better option compared to a normal saline. Next, how much fluid to give? So this effort has been initiated by the Rivers et al. In 2001, and this is a goal-directed therapy protocol. Then they have marked some certain endpoints while you are giving fluid resuscitation. So you have to give certain amount of fluid, target a CVP, and after that probably we have to give vasopressor to target a mean arterial pressure, and at the end if the hemoglobin is low, probably we target around hemoglobin of 9 and 10. But what happened in the present era, because of our physiological understanding has improved significantly, multiple goal-directed studies like ARISE, PROCESS and PROMISE, which has been performed in last few years, does not show any extra benefit with a goal-directed therapy. The main reason behind it is that we have already incorporated the physiological concept of goal-directed therapy in our regular practice. So probably we are, even unknowingly, we are basically practicing goal-directed therapy or a structured way of patient resuscitation, probably not using the SCVO2. That's the only component that we are presently not using in our regular practice. About early vasopressor, the present recommendation is to use norepinephrine as a first line of agent, followed by vasopressin, and after that adrenaline. And this has been recommended in the surviving sepsis guideline also. And if the patient has a cardiac dysfunction with a persistent hypoperfusion, then probably even after fluid resuscitation and blood, then to consider dobutamine or switch to epinephrine maybe little early compared to the standard recommendation. In terms of vasopressor or inotrope, the study journey first start with the dopamine. Initially people has used dopamine as a renal protection. That has not worked. After that, when we have studies comparing dopamine with noradrenaline, we understand though the outcome is reasonably same, but there is no significant mortality benefit, but dopamine causes significant increase in cardiac arrhythmia. In a subgroup analysis, it shows in a cardiogenic shock, dopamine also increases mortality because it causes significant disbalance between the oxygen demand and the supply. That's why the present recommendation is to start noradrenaline even in a cardiogenic shock. And this has been shown in multiple studies, and that's why it has been emphasized in recently very much. Please start your vasopressor early. Don't keep your patient hypotensive for a very long time when you are going for the fluid resuscitation. Now, what regarding the vasopressin? When to start vasopressin? Vasopressin usually we start when the noradrenaline level is very high. But here the studies in the VAST trial has shown that if you start vasopressin little early rather than waiting too late, then probably the outcome may be little better. Vasopressin will help in two ways. One, it acts in a different receptor in septic shock, and also there are patients who has a relative vasopressin deficiency in sepsis. So in that aspect also vasopressin may be helpful. Studies shown that if you use vasopressin and noradrenaline in a very high dose, those vasopressors has cardiac effect and eventually they may cause cardiogenic cardiac toxicity and have a poor outcome. So present understanding is, can we target a lower blood pressure, or can we use vasopressin over noradrenaline to have a renal protection? One is called VANISH trial, and second trial is target a low blood pressure specifically in elderly patients. We target a 65 of MAP. Both are negative trial. They does not found any extra benefit over our standard practice. So we do not need to any individualize our standard patient management in this subgroup of patients. Another vasopressor probably will be in the market in few due run, that is angiotensin 2. It will again act in a different receptor. So we'll see how is the outcome. This is a negative non-inferiority trial that was published in EDICM. So probably in next few years it will be available for our clinical practice. What are the other supportive therapy? We know about the hydrocortisone. In the sepsis, when the patient has a refractory shock, not responding with the vasopressor, hydrocortisone is an adjuvant therapy that we usually add. And the drug of choice is hydrocortisone with 200 milligram per day as an infusion as per the present recommendation. And some studies have recommended to add fludrocortisone also, but these are again soft data. This has not been replicated into multiple studies. It is mainly the NNA who has found fludrocortisone advantage in his practice with septic shock. What about vitamin C and thiamine? This is Merrick's trial, which was a really, what should I say, apparently shown to improve mortality by nearly 50%. But eventually, if we follow up the studies, it shows that only hydrocortisone is probably helpful. Regarding the vitamin C and thiamine, presently these are not strongly recommended in sepsis management. Thiamine probably important if you think of thiamine deficiency with a high lactate, but vitamin C's role in vitamin C as an antioxidant in sepsis is really questioned in last few studies and also in RCTs. About early antibiotic, we all are aware of Anand Kumar trial, which shows that if you delay appropriate antibiotic even by hours, mortality increases significantly, as high as 6 to 7%. And as a result, the heat fast concept was in the critical care and in emergency. Whenever patient is coming, even we have a minimum doubt of sepsis, we start giving them broad spectrum antibiotics, and as a result, over the last few years, the resistant pattern has worsened significantly. We are seeing a lot of carbapenem resistant, colistin resistant bugs in the multi-speciality or the tertiary care hospitals. So the modification has been changed little bit in last year 2021. So it's a differentiate patient on the basis of shock. So if the patient has a shock, that means patient is suspected to have a septic shock, and you are thinking of infective cause, please start your antibiotic immediately within 1 hour. If the patient is not in shock and you feel that the non-infective cause can be there, so you can hold back your antibiotic and can evaluate the cause, and if you're still not sure that infection may be a possibility, give your antibiotic within 3 hours. So now we have around 3 hours to evaluate your patient who are presented to the emergency not without septic shock, not in a patient who is in shock, so that we can streamline our antibiotics better. And whenever we are dealing with antibiotic, what we have to do, we have to optimize have to have a very good understanding of the PKPD. We are living in an era of MDRO. We will get lot of antibiotics, lot of bugs which are resistant or intermediate to most of the broad spectrum antibiotics. So PKPD is a main guidance to help us regarding choosing our antibiotic. So if a patient is showing an Acinetobacter in lung with a minocycline and tigecycline, both are intermediate, probably we'll go with a minocycline because it concentrated better in the lung compared to tigecycline. So these understandings we have to use in a regular practice to choose our antibiotics appropriately. Last few slides on the biomarker. So most of us have used extensively CRP and procalcitonin, but if you look at the sensitivity and specificity, it is mostly 0.7, 0.8. That means around 20 to 30% cases probably it will overdiagnose or misdiagnose as sepsis. Probably procalcitonin has the highest area under the curve, and most of the studies have shown that if you use procalcitonin guided de-escalation of therapy, probably it will be helpful in decreasing the duration of antibiotics. In initiation of antibiotics, biomarker does not have any role. Please be very clear, there is no role for procalcitonin or any other biomarker to decide initiation of antibiotic or diagnosis of sepsis. But the problem is that these are all Western data and they rarely have MDROs in their situation. So probably can we extrapolate this understanding of procalcitonin guided de-escalation in our practice when you are dealing with so much MDRO is very, very challenging. There are two meta-analyses which shows that if your duration of antibiotic is more than 7 days, and if you de-escalate as per procalcitonin, predefined procalcitonin, maybe 0.5, maybe 0.25, depending on your practice, probably you can decrease the duration of antibiotic by 1 to 1.5 days. Now, whether we're going to do that to save 1 day of antibiotic in country like us, that will be our clinical judgment. But the prognosis, in terms of prognosis, it is very important. So if your patient is not responding clinically, but your procalcitonin is progressively increasing, probably they need a close monitoring rather than de-escalating and shifting out of the ICU. And there are a lot of other new novel biomarkers are coming, which are at the research level. And probably what we basically need a biomarker signature that will send multiple biomarker, and from that we'll get some idea that whether this patient is septic or not. And I think these are still in the research level. We don't have any clinical experience in these terms. There are certain rescue therapies that we have tried in sepsis, like high volume hemodiafiltration, which has been done in Ivory and HiCODIS trial. What they have tried, they have to remove the cytokines, which are so-called the causative factor of end organ damage. By this method, polymyxin B hemoperfusion therapy, which removes the endotoxins, or blood purification technique like cytosop, which adsorb the cytokines within a certain volume, certain size, up to 40 Dalton. And also in IVIG, suspecting that this patient is immunocompromised. But all these trials are negative. So basically, when managing sepsis, we are still dependent on our basic clinical understanding, good initial resuscitation, appropriate antibiotic after sending cultures. And we should not forget about the supportive therapy in terms of the first hug, like early initiation of nutrition and DVD prophylaxis. Probably these two is very, very important along with the definitive therapy for our patients. And to conclude that though after initial resuscitation our patients may come out of the ICU, but we have to think to give them a better long-term outcome. That is our main target. So in that situation, early initiation of nutrition, early mobilization, become very proactive to wean them off from the ventilator, keep the psychological issues, addressing the psychological issues of the person, like addressing the delirium, do multiple physiological intervention to prevent delirium in our ICUs are very, very important. So a lot of things could not be discussed because of the time issue, because sepsis is a very, very broad aspect. I try to emphasize on the points which we are doing in our regular practice on a daily basis, specifically in the initial resuscitation. And by this, I like to conclude my presentation. Thank you, everybody. I'll be happy to take any questions.